opioid epidemic in Oklahoma. This third part of the series will be recorded, and again, we'll send links out to everyone so that they can view these if they would like to view these in their own time and leisure. But I wanted to kind of finalize this. A little bit of this will be repeat from the first two series, but that's part of the goal, which is to build on the information we provided in the first of the two series. So the agenda today is, number one, who's watching our prescribing practices? For those of us who are prescribing controlled substances on a daily basis, I don't want anyone to be lured into the idea that this information is going into a vacuum and no one is looking at this. There are a lot of people who are monitoring our prescribing habits, and we don't want to be the last person to identify this. So I want to talk a little bit about that. I want to talk a little bit about the legislative response at the state level and what the state of Oklahoma is recommending in terms of helping us work on this epidemic. I want to talk a little bit more about medication safety, pain management referral, and substance abuse options. And so that's kind of the agenda for today. I'm going to start with, I think, every provider's worst fear, and that is turning on the TV and recognizing the fact that you are the subject of an investigation. And this is an example of something that was in the news last week. As you all probably have seen, this is not the first time a provider has been in the news about prescribing controlled substances. This particular story was initiated after recognizing that there had been somewhere between 4 and
Record your message at the tone. When you are finished, hang up or press pound for more options.
And I'm just going to remind everyone, please mute your phones when you sign in. But anyway, this again goes back to the idea that the last thing we want to be known for is that provider who was on TV last night in the news. This is the other picture is a picture of the DEA
you can see it here, Peggy,
from an office. And so, as I said before, none of us want to be this provider. None of us want to be the person who didn't think that they were being monitored and then found out otherwise. So what is triggering prescribing monitoring, and who is watching this? The first thing that I think everyone will identify with is that narcotic-related deaths are the key trigger for any investigation. And so when prescription medications are tied back to a narcotic-related death, that provider's practice will be at a high level of review. And if this is one incident, it may not trigger investigation, but if there appears to be a pattern, this clearly will trigger an investigation. The other thing is that the prescription monitoring program data is being reviewed and monitored on a regular basis. It's being monitored by multiple entities, including the licensure boards. But the things that are throwing out red flags for them are providers with high morphine equivalent doses of medications, patients who have medications prescribed from multiple providers, suggesting that the providers are not tracking the PMP site, and also patients who are on narcotic benzodiazepine combinations. These are all red flags that are then increasing providers' visualization into prescribing habits. They also are looking at pharmacies as well, and so the PMP is very aware that there are certain red zones across the state of Oklahoma where high levels of narcotic and controlled substances are being dispensed at the pharmacy level, and so they're identifying pharmacies that are also perhaps implicit in some of these issues. Complaints to the Oklahoma Bureau of Narcotics also trigger investigations. Unfortunately, the OBN only has about 6 full-time employees that are in the field and investigating complaints, and so for the most part they're fairly overwhelmed. We've been involved in situations where a pharmacy has filed a complaint against one of our providers, and so pharmacy complaints again trigger the review of prescribing practices by providers. and patient complaints. And that's just not patients, that's patient and family member complaints. This situation can happen because a family member feels that their family is being prescribed inappropriately. This also could be a family member or a patient who, for whatever reason, is no longer receiving controlled substances from a provider and decides to blow the whistle on them to law enforcement. And then lastly, medical boards are reviewing all of these databases and monitoring all of these practices. And it's not uncommon that the medical board is the first entity that approaches a practice with a complaint. And to really further this discussion, when we look at non-fatal overdoses, now fatal overdoses may mirror this to some degree, but when we look at non-fatal overdoses, you can see that despite the fact that there are many opportunities for people to obtain illegal drugs over from illicit sources, prescription medications are by far the most common place where overdoses begin. And again, it's implicit on all of us to be aware of our prescribing practices. Another place that we see data on prescribing habits is ProPublica, which is a online publication that monitors all kinds of activities, but they're very interested in what happens in the medical field, and they are able to download large databases and review databases. You can go into this database at the website address that I've listed and look at providers by state, by specialty, and identify how they prescribe and how they compare to their peers. Again, you can also filter this database by controlled substances, and this is an example of a provider who prescribes medications. For many providers in the state of Oklahoma, hydrocodone may be the number 1 or number 2 prescribed medication of their entire armamentarium of medications. And for this reason, you'll see that this is the number 1 medication prescribed by this provider, followed by several other medications. This is a nice database to compare yourself to your peers' prescribing habits and review primarily Medicare-related patient data. The other thing is that we now are looking at prescribing through through NextGen in our practice. And what we basically have done is looked at the total number of prescriptions for controlled substances that are written by each one of our practices annually. And then we take and do a calculation where we divide this total number of prescriptions by the number of unique patients seen by each provider. And we get a final calculation here on the far right side. So basically what we're looking at is the number of controlled substance prescriptions per patient per year. An example is if one patient receives 12 prescriptions for hydrocodone over a year's time, that would be a number 12 for that patient. But when we look at the entire database, we can compare prescribing patterns amongst providers. And you can see in this example, you have providers that have a score of less than 1, and one provider whose score is 4 times higher than some of his peers. And so this, again, triggers our thought process around why is this one practice prescribing more controlled substances than other practices. And based on this data, we'll be talking to some of our providers about practice patterns. We know for a fact that the percentage of controlled substances is written by any provider will be dictated to some degree by their specialty. Orthopedic surgeon, general surgery, they may write a higher percentage of total prescriptions being controlled substances, but that total number of prescriptions is still going to be relatively low. And so we look at this entire database, and we are monitoring now how each one of our providers compare to their peers. So going back to the Oklahoma Commission on Opioid Abuse, they had 31 recommendations. I've included the website for this. but I want to kind of just briefly go over these. Mandated e-prescribing is one area that we've talked about, and we will mandate e-prescribing for all controlled substances when we go live on EPIC. And I think this is going to be an action that the state will continue to pursue, requiring medical clinics to register with OBN so they are aware of the location of all clinics in the state. One thing they've really proposed is limiting quantities of the first prescription for opioids. What they're trying to do is limit how many days a practice is prescribing, for example, after a dental procedure, so that patients aren't getting 3 and 4 weeks worth of medication for a problem that should only last 2 to 3 days. And then again, they're looking at how do they fund additional substance abuse training, and an example would be a tax on opioid manufacturers. And so again, this is areas where they're truly trying to determine what the best way to provide additional resources back to providers. Again, encouraging the use of Suboxone, and I think that most people are in agreement that withdrawing all narcotics from patients who are at risk is probably not the best treatment modality. They're looking very strongly at creating databases based on overdose events in the emergency departments, where a lot of times these are lost. And so that gives them better insight into which patients are suffering ill effects from narcotics, and then tracking that back to the prescriber. Despite the fact that DOs are required to have 1 hour proper prescribing every other year, they've recommended that all providers receive 1 hour of training annually, and then additional issues around mid-level prescribers, APPs, and these are all ideas that have been floated, but none of these have been finalized in legislative actions. So what else can we do as prescribers? Again, focusing on non-narcotic alternatives for our first step. I think we all have a tendency to pick an easy path. I think topical therapies, anti-inflammatory medications, things like gabapentin are all reasonable options. Physical therapy, pain management for local injections, all of these should be our first alternatives. And every time we prescribe narcotics, it should be at the lowest dose and the shortest period of time. We should spend more time with patients setting realistic expectations that we intend on taking them off of these medications at some point in time when appropriate, and setting realistic expectations. We need to understand that when patients are on narcotics and receiving minimal benefit, that they should be taken off of the medications. If there's not a clear improvement in their level of functioning, then these medications should be removed. We've talked about this on several occasions, is not prescribing combinations such as narcotics, benzodiazepines, and muscle relaxers, primarily soma. I think most people are well aware of this, but we still have a considerable amount of being prescribed in combination with narcotics. And again, this is areas where we'll be spending more time looking at our internal databases and identifying providers who are utilizing soma in combination with these medications. I think it's very simple to tell patients if we're going to prescribe a controlled substance like a narcotic, we will no longer continue to prescribe a benzodiazepine or soma in combination. And I think that drawing that line early in a discussion makes it much easier down the road. I would strongly encourage people to continue to have those conversations about risk versus benefit on pain medications, and I think that the patients need to be aware of the risk as well as the potential benefits. We've talked about informed consent, urine drug screening. All of these things need to be informed when the patients need to be informed upon the first prescription so that they are not caught off guard afterwards. Utilizing naloxone and referring patients to treatment programs, and I'll talk a little bit more about that. Medication safety is also very important. As you all know, many times we've had situations where patients will call and tell us that they can't find their medications. They think someone has taken them. These things need to be stored safely, and when they're not being used, they need to be disposed. One thing we know for a fact that teenagers more often than not obtain medications like controlled substances from family members the first time they've been exposed to them, and based on their own personal curiosity, this is where many times we see addiction begin. So I think it's important to recommend there are things like the MedSafe, which is a tool, a device that can be purchased on the internet, or even a $100 gun safe for handguns, where these can be locked up and kept away from family members. Medication disposal is important also, and there are lots of resources. The state of Oklahoma has a take-back program, and you simply just type in the website a zip code and how close you want to be to a site, and it'll give you a list of all of the police stations and pharmacies that will take back controlled substances. And Walmart also has multiple sites where they have a disposed RX powder in which you just simply take your pills in a bottle, mix this powder, and then pour water, and that causes the gel to form and then hardens, and it protects the pills from being abused, and then it can be thrown away with the trash. And these are free if you ask, and Walmart has a list of these locations where you can obtain this powder. So when do we refer patients to pain management? I think many of us have been concerned about how much more pain management we wish to continue and how much more risk we want to accept in our practice. I think that any patient who has a morphine equivalent dose of 60 milligrams a day or higher should be considered for a specialty care. As I mentioned before, this is what the morphine equivalent dose looks like. A 50 milliequivalent morphine equivalent day would be 5 10 milligram hydrocodones a day. That seems like a lot, but it's not uncommon for some of our patients to exceed this. Any patient who has a diagnosis of pain, who has been treated with a narcotic, for whom an evaluation has not been formally performed, or it's unclear what the diagnosis for the narcotic use is, should be considered as a referral for pain management. We've had patients come in who tell us that they have this illness or that illness, but we don't have any real evidence of a clear diagnostic workup. Those patients should be referred for specialty care before the pain medication is continued. Patients who have difficulty with adherence, and those would be those patients who are routinely requesting medication refills, who claim that their medications have been lost or have been spilled or they've been stolen. Any of those patients who raise those red flags should be considered for referral for specialty care. Any patient with high risk for drug abuse, I think, should be referred for a specialty care, because the monitoring process is much more robust in those specialty programs. Any patient who's had a history of a drug overdose should be managed by specialty care. And I think any patient who you feel uncomfortable of weaning from narcotics, or you've struggled with weaning from narcotics, should be referred to a specialist for care. There are some patients that as we begin to lower their dose of narcotics, they begin to complain of multiple list of issues and use that as an excuse to try to prevent any further weaning from the pain medications. If you get uncomfortable with this process, it's easier to refer to the specialist and let them assist you with this, especially if people are having significant narcotic withdrawal symptoms. In that situation, it's important for the specialist to know what you want them to do. And if it's simply to help management of weaning from the narcotics, be clear with that on the referral. The other thing I think is important to remember is we do not want our patients referred just because you don't want to prescribe controlled substances. Our pain management doctors are busy enough managing these chronic conditions, and an influx of patients who are on 10 or 20 or 30 milligrams of hydrocodone a day and appropriate in their care do not need to be managed by a pain specialist. These patients can be easily managed in our practice as long as they're compliant and adhere to the treatment plan. And so what we don't want is our specialty providers to be flooded with stable patients who don't meet any of these criteria above. Medical treatment for addiction is really important as well, and although this can be a real challenge to identify these patients, I think it's always about how we approach this. Avoiding stigmatizing language like you've become addicted or you're abusing your medications truly positions the patient in a way to push back. When we look at this more as a medical condition, such as using terms like substance abuse or substance use disorder or opioid use disorder, and we wrap that around the behaviors that they've demonstrated rather than their intent, I think it's easier to assist patients in obtaining assistance. When we talk about behaviors, it's calling in inappropriately, calling in early, all of the things that we've talked about. Borrowing other people's medications, calling to say I'm going to be leaving town in a couple of days and I need to make sure my medications are filled early. And when this happens over and over, we know that they are manifesting their behaviors in a way that is more reflective of a use disorder rather than just bad addiction behavior. And lastly, we have lots of resources at UPC to assist you with finding resources, and the social workers that we have are very good at identifying community resources. Remember, there's several options for medical treatment. Identifying these patients and offering those options are very important, and then getting them referred to a program where these treatment options are available, I think is really helpful. Buprenorphine is one medication that in combination with naloxone, it seems to be the gold standard, but naltrexone in an injectable form for a monthly injection seems to be also helpful in some people. So we have several options to provide to patients to help them wean from narcotics if necessary. And there are treatment programs across the country like the Suboxone.com, University of Oklahoma, and I've listed several different locations that I've used in the past. We also have some online treatment finder programs that are available as well, and that's included in the presentation. Lastly, tapering narcotics. There are many times to consider tapering, but the best is when patients say to you, I just feel like these medications are causing more harm than benefit, and I'd like to get off of them. We also have to look at patients who don't have improvement in their PEG scale. And the PEG scale is really just how has the functionality and quality of life changed on these pain medications. And this is just simply a three-question pain, enjoyment, and general activity scale that you can ask that helps quantify how well they do before and after they've initiated therapy. The other thing is really assessing how well patients function when they're on high doses of medications. I feel strongly now that when patients exceed 50 morphine equivalent doses and are on concurrent benzodiazepines, that the benzodiazepines need to be stopped or weaned down, and then the patient functionality monitored. Anytime we have patients who demonstrate signs of substance abuse, it's time to taper narcotics. This is family or work-related impact, difficulty with controlling use, etc. And any evidence of adverse effects. We've all probably seen these patients who come in complaining of pain with slurred speech or sedation or confusion. these are all patients who have to be tapered down on medications. All tapering is individualized. Some people can be tapered more quickly, but the longer they've been on medications, the slower the taper has to be. I typically will begin tapering by lowering the dose, so to go from a 10 milligram hydrocodone to a 7.5 milligram hydrocodone every 6 hours, and then I begin to increase the interval over time. Sometimes I'll just simply monitor by decreasing the number of pills per month, so it may be 90 pills per month, and then I'll go to 80 pills per month. And do this every month until you feel like the patient is at an appropriate level of medication. Support needs to be provided, and when you start the tapering process, don't stop. It's important, and when I say don't stop, what I really mean is don't go back to the initial level. So you may need to slow the taper down, or you may reach a threshold where you feel like this is the lowest dose that controls your symptoms, but once you've committed to tapering, don't return back to higher levels of medication. That's always a challenge, and patients will push you to go back to initial doses because of a new injury or a new complaint or a new problem. Focusing on non-narcotic pain medication and management is important, and then managing depression and anxiety, because all of these patients will experience a level of both as they continue to taper medication. So that kind of wraps up our third part of the series on opioids. This is clearly a complex process, and I've just barely touched the surface for some of these issues. But I'd appreciate any recommendations you have from your own personal experience. I'd be happy to share them with the entire group, and would love to hear feedback from you. In the future, we'll be talking a little bit more about other things we can do in our practices, and more one-on-one conversations with practices that may have struggles associated with this. So have a great afternoon, and appreciate everyone's attention through this series of webinars. Thanks.